Hi, so this is my neurosurgery presentation on a cerebral aneurysm repair. So what is an aneurysm repair? It is a surgical procedure that involves removing a portion of the cranium to access and repair or clip a cerebral aneurysm. So it's performing a craniotomy to access a cerebral aneurysm. The goal is to isolate the aneurysm from the parent vessel by placing a specially designed clip across the neck of the aneurysm. And if the aneurysm cannot be clipped for whatever reason, the sac of the defect will be reinforced with synthetic materials like polymethyl methacrylate or mesh gauze. Or the feeding vessels might be ligated. There is also, these are like the different ways that an aneurysm can be clipped. And then this is the endovascular approach. So the endovascular approach is more of a peripheral vascular type approach. It normally goes up through the radial artery, and they use image-guided navigation to make their way up to the brain, the brain vessels. And basically it's the use of platinum coils to clot the aneurysms with the use of a catheter to access it. So platinum coils, they are inserted and released into the aneurysm, and some way, somehow, that stops the defect. So what anatomy is involved in an aneurysm repair? So there are a lot of possible arteries, vessels that could be involved. So I included a picture of the circle of Willis. This is the circle of Willis, and then these are like all of the arteries that could possibly be involved. But other than that, your scalp, they have to incise the skin and retract the scalp. The skull, typically the frontal or temporal lobes, bones, and the lobes. The sylvian fissure, which is where they take the open approach through. All of this does depend on where the aneurysm is located, but typically, and most commonly, this is what they'll do. They also have to access the dura mater, arachnoid mater, pia mater, which are the meninges, brain tissue. They have to be careful of the brain tissue, the circle of Willis, the pituitary stalk and hypothalamus, cranial nerves 3 and 4, the optic nerves and optic chiasma, and the subarachnoid space, because you don't want a hematoma. So the indications for an aneurysm repair are pretty simple. Either you have a ruptured aneurysm or you have a large unruptured aneurysm. If it is a smaller unruptured aneurysm, the doctor might choose not to operate until it's necessary. There are a lot of circumstances that go into that decision. Maybe the aneurysm can be managed, but for the most part, they probably will clip the aneurysm. These are some different sizes of the aneurysm. This is like about the point where they start to get really concerned. And then symptoms of a ruptured aneurysm, I know that these are the indications, but the symptoms, meningeal irritation, focal signs of cerebral damage, uniformly bloody spinal fluid. They might do a spinal tap to see, and then these are more symptoms, but these also apply to a quickly growing unruptured aneurysm that might be about to rupture, but these are the main symptoms for a ruptured aneurysm. However, most aneurysms do not cause symptoms until they rupture, which means someone could have a growing aneurysm for years and straight up not know it. But it's a very unpredictable condition. So preoperative diagnostics, family history and a physical exam. If there's a family history of aneurysms, that's pretty important. And then the main diagnostic procedure is an angiography. You can also use an MRI or CT scan, but angiography perfectly will map out the aneurysm. This is an angiogram, a CT angiogram of a basilar bifurcation brain aneurysm. So it's in the basilar artery. As you can see, this is an image of what everything is supposed to look like, what your no aneurysms are in this image, and then this is just another image of an aneurysm. So for the surgical counts, you're going to have 3 counts. Your initial back table setup, your first closing count after the dura is closed, your second closing count is performed during skin closure, and you're counting sponges, sharps, and extras. There will probably be things added to the field, so you're going to want to do extra counts for things added to the field, changes of personnel, since a lot of the supplies might be small, you want to be very diligent about keeping track of everything. So the positioning and positioning aids, so this all depends on the approach of the, well, it depends on the approach that's being taken and the location of the aneurysm, but most commonly it's going to be supine. You can access temporal, parietal, and a frontal. It can also be supine, sitting, or a lateral position, but for supine, there will be a donut headrest, a 3-pin skull fixation device, pillows, pads, blankets, chest roll, maybe for the neck, a safety strap over the thighs, 2 inches above the knee, and then around the arms. Being tucked or untucked is up to the surgeon. For prepping, you want to assure that the eyes and ears are protected from the prep solution. The hair in the area of this incision will be shaved off, but the hair can be saved if the patient requests it. The head is prepped with an iodophor scrub. The surgeon might also go back over the iodophor scrub with, like they might paint it with alcohol or iodophor paint. And then for draping, 4 towels and impervious craniotomy drape. And then there might be additional draping for the operating microscope or a C-arm. And then the incision is a U-shaped incision behind the hairline. I kind of was thinking, and especially it shows this in the video that I linked, it reminded me of a facelift incision, except it goes out a bit further. So instruments that are involved, a craniotomy tray, microsurgical instrument tray specifically from neuro, aneurysm clip applicators, Rainey clip appliers, a carotid instrument set for the carotid artery exposure. The equipment includes the operative microscope, the C-arm, an ESU unit, suction unit, power source for the drill for the burr holes, SCDs, and a bear hugger. So the operative microscope will be used during the surgery when they're clipping the aneurysm, and the C-arm may be used at the end of the surgery for an angiogram, just to make sure that they got everything. And then for supplies, permanent and temporary aneurysm clips. They might use a temporary aneurysm clip to test the placement for a permanent clip, or to occlude the parent vessel if a rupture occurs during the surgery and they can't see it. Hemovac or Jackson Pratt drain with silk sutures, Foley catheter tray, 10, 11, 15 knife blades, marking pen, cottonoid patties, because this is obviously neuro and you can't use big, but lap sponges are used when incising the skin. Rainey clips for scalp retraction, and then bone wax, and definitely nerve monitor. So this is the link for the video. I'm also going to link it into my discussion post. This is a 6-minute video, and my program that I use will not allow me to record that much time, but I will link it in the discussion post, and I will also link this presentation so it can be clicked through there as well. So dressings, you're going to have an inner contact gauze, probably like petroleum gauze, 4x4 sponges, and Curl-X wrapped around the head. Your wound classification is class 1 clean. And then the medications, there are a lot of medications that can go into this. I listed the ones that I think are pretty important. Obviously, general anesthesia and a local anesthetic with epinephrine for hemostasis, papaverin to prevent vasospasms when the anesthesiologist uses sodium nitroprusside for hypotension. They're going to also use papaverin to prevent vasospasms. Irrigation, antibiotics, pain management, probably more morphine than acetaminophen, and then calcium channel blockers. So post-operative care, you want to be so careful when moving the patient from the operating table back to their stretcher. Do not drop the head when you are removing the fixation device, and especially be mindful of the head when moving the patient. The patient will be taken to the PACU or ICU with monitoring lines, a urinary catheter and drainage bag, and a wound drain. Those will probably all be removed within 48 hours. They will stay in the ICU for about 24 to 48 hours, and they'll be discharged after 2 to 3 days. And then some complications include wound infection, meningitis, neurological deficits, intraoperative damage to vital structures in the brain, which can cause the neurological deficits, subdural or epidural hematoma, intracerebral hemorrhage, subarachnoid hemorrhage. And these are my questions and answers. And then this is my bibliography.